I have been working almost 20 years in the social and healthcare sector, but I'm economist by profession, but I don't know anything about that. So I'm ICT architect, have to admit, but I know some healthcare and social and welfare. But why I am here today is because we made an evaluation of international data models for primary use in Finland. So how to apply international data model standards or standards in general in Finland. And as was mentioned earlier, hands-on, it's not hands-on exactly because this is a study that was in written form and so on. We didn't do any proof of concepts or anything like that, but of course we have a good proof of concept in the Finnish national system. But anyway, the Ministry of Social and Healthcare appointed Social Insurance Institution of Finland, which is abbreviated KELA, to perform a study on international healthcare data models in order to provide an overview of the current standards and to evaluate the usability for Finnish use cases, as well as provide guidelines for future development. I was working there as a consultant, obviously. The focus was on the healthcare data, so we are talking a lot about social and healthcare integration in Finland, but no, it's okay. Yeah, but for this study, the purpose was the healthcare. So we kind of limited it, but we take a slight jump also to the social care there. So the additional viewpoint to consider was the integration. Also, the secondary use was in perspective, but it was on a smaller account and especially on the services system development and governance. And more than 30 expert reviews were done, and also TEHIK, so thank you who participated. So we started from this kind of situation that we have certain drivers for building or adopting a data model in Finland. These are actually what Kerli just said earlier. It was so similar to Finland. Maybe it has taken us a bit more time, but we are somewhere in the same place. So we have lots of challenges and needs in primary use as well as the secondary use. We have huge challenges in our service system, financial challenges as well as the others. Then we have the European EHDS coming, and it's coming quite fast on our viewpoint at least. But of course we are quite ready for it. We have most of the services in place already. There is a government program of the current government for the cooperation of public and private and occupational and student healthcare. So that is one important topic that mostly in Finnish discussion we talk about public healthcare, but we have a huge system outside of the public social and healthcare. Then the possibilities of the emerging standards that have been extensively discussed today. The burden of structured documentation for the clinicians, that's the same everywhere, I guess. Then we have the international classifications and national classification strategy that was just released. And of course the generative AI possibilities. So with what we saw that were prerequisites for the data model, of course we need to start from the social and healthcare professionals' needs and the purposes of use for the information model. And it was kind of conscious decision to talk about the purposes of use, even if there is another approach that you shouldn't limit the purposes of use beforehand. You should make the data available for all the purposes of use. But this was something that we discussed in the group and decided that we need to have some kind of viewpoint on that. Then value assessment decisions on the information model. This is something that has maybe been neglected a bit in the previous developments, and it has caused some problems, but I'll come back later to them. So what are the elements of the data model? The chosen reference model, definition of the structures, classifications, value sets, and so on. Of course, the governance model and the modeling tools, etc. So where are we now? We have had the Kanta system in place since 2010. That is something similar that is being done in Estonia as well. And it's the current enabler of interoperability in Finland. And it's mandatory for all the social and healthcare providers to connect to Kanta system. Transmission of data to national system must take place without delay, it's said in the legislation. That is, of course, a bit interpretable, but anyway, I think we are currently at a quite good point in that. But anyway, as was discussed about being document-based, Finnish system is document-based, yes, for the most part. For the electronic prescriptions, it's event-based. But there has been maybe 10 years discussion, and even the clinicians, they have, of course, because they haven't had the tools, so they see that, okay, all the data in the Kanta archive, it's PDFs or something like that. But it's, as Kerli said, also here, it's structured data. For the most part, anyway. But we don't have the patient-centric data model currently, and that's why this study was being conducted. And as I said, we are quite well off being EHDS ready as well. And about the classification strategy, so we are going the same way that many others as well, SNOMED CT, ICD-11, and also other WHO classifications, as well as the LOINC. We have had this FinLOINC earlier, but now standardizing for international one. And of course, we also have the local standards, local data sets as well, but it's progressing on that side. This is history of standardization in social and healthcare in Finland, and as I said, it has taken maybe a little longer for us. We started in '95 with HL7 Finland founding. We had the national core data sets defined in 2003, I think. And then the ministry chose to use HL7 CDR2 in 2004, is it? And in 2015, all the public healthcare uses patient data repository. And currently, we have had the reform to well-being county organizations instead of the municipalities that were hundreds of. Now we have 21 well-being counties that are providing the public social and health care. We are making the movement towards FHIR as well. And we are starting from the new interfaces mostly. This is just a short overview of the high-level architecture. So we have the prescriptions, we have the patient data repository, we have this kind of aggregate service as well as the consent management service, the data management service. So we aggregate the for instance, the diagnosis or the vaccinations or the risks or such. From the CDA documents, we extract them and provide interfaces to use in the summaries. Then we have the data repository for social services and data lake for health and social and welfare, and there are the main standards down there. But I guess you get the slides, so maybe take a look at that. So where are we at a regional and local level? We have had very heterogeneous service system, as I said, many hundreds of municipalities, but nowadays it's 21 well-being counties as well as the private sector providers. Currently, the information landscape is still quite heterogeneous as well, but there is consolidation taking place. The data models are either proprietary, FHIR-based, or open air-based, but actually we don't have published archetypes, nor do we have actually some FHIR resources in the Finnish FHIR resources set, but so many different types of systems. And unfortunately, we are at the quite early stage of current systems life cycle. So the procurements have been just made because the well-being counties have been starting, and so we cannot force the well-being counties to go to one type of EHR or something like that. So this is a depiction of that. So there has been separate systems for specialized care and primary care, but now they are like focusing at least in the sometime next year. So we will be having 4 public healthcare systems in place. And it's noteworthy that the open air counties are orange, and the blue ones are either Omni from CGI or Epic in the capital region, and ESCO in the northern Finland. So the university hospitals use ESCO, Omni, and Apotti, but many of the others use Life Care, that is open air based. Then we have the multiple private healthcare systems as well, and of course the lab and radiology and everything else. So there has been discussion about the patient-centric data model, that is the objective, and we have defined the purposes of use for this like that it's the shared patient-centered information model for healthcare that defines the structural content of essential health information accumulated throughout the person's life. And the primary goal of the model is to improve the effectiveness of care and services by supporting workflows, strengthening the active role of the patient, basically the customer, and his or her close network, and ensuring the quality and consistency of the information produced. And of course, this should provide help for exchanging data across care and service boundaries, also on the EU level. It should be sufficiently detailed to support the care guidelines and the decision support solutions and so on. And this is, of course, important that the information structured with the model can be reorganized so that it can be used for secondary uses as well. And of course, it can be combined with other data sources, as was earlier here well explained. And the purpose of this is not an EHR data model, but the model that the EHRs must be interoperable with. So there are just some data sets that are in the focus, but I think that I will skip over this. So for the actual evaluation, This is those text that is on the very small font. I might be reading through some because that's what. Because all the time, every time that you present something nowadays, you need to have something from generative AI. So I made a couple of funny notions about the standards. But anyway, so the vertical axle here means that on the topmost corner there are the semantically most complete information architectures or models, and the lower part means that it's the core data mostly. Then on the left there are the domain specific, and in the right corner are the cross-domain standards. This is of course our team's opinion. It could be looking a bit different, but one interesting thing is the DICOM, because DICOM is, as Hanna mentioned, it's de facto standard for almost everything in imaging, as well as the ECG and pathology and whatever nowadays. But still it's quite domain specific. So of course, if we take all the healthcare and the patient records into account, it's kind of different ball game anyway. But we also need quite a bit of those patient coordination and patient administration stuff in our data model. So HL7 Fire for that is on the kind of good corner. OpenAir, it's semantically complete and it's quite wide, and as you will see, we are definitely going to use it in the modeling. Yeah, so actually the text there, for instance, for OMOP, it's I don't know how you see it, but it says that for counting the right things but without nuances and not asking why they mattered. I don't know, how about that? Well, for Fire it says for always being ready to speak but only makes sense when you agree on the grammar. Yeah. And OpenAir, it's for being fully aware what is being talked about, so the data model part, but still needs work on agreeing how and whether to say it. DICOM for never losing the picture, but often needing help to develop the details. Yeah, quite okay. So we looked at the standards on different viewpoints, and they are listed here. I have a huge table that contains all the standards. Of course, the standards are for different purposes of use, so this is quite unfair anyway, but just to somehow make sense of them. Okay, modeling and formalization of clinical domain concepts. Of course, this is where OpenAir shines. General applicability for patient-centric data model as per the standard limitations, granular and broad enough platform for given purposes of use, complex and full meaning data exchange, semantically interoperable platform for heterogeneous source EHRs, detailed and multipurpose data persistence, EHDS compliancy, and market support and expertise available. Some of these were loaned from this article, and some of those were discovered by the project group. But anyway, I don't have the table of the evaluation, but I'll go through to the actual proposed framework. So for the given purposes of use, no dependency on single data model, as none of the standards, of course, caters for all the needs. That's clear, and all need localization. That's clear as well. Was it Hanna that said that OpenAir should support 90% of the need? And for Fire, it was 80, but it seems that maybe it's 65 or something like that. I read some study about that. No forcing on specific data model. You heard the reasons. So basically this is evolution to what has been done in Finland for the last 20 or more years. But we need to focus more on the priorities. We need to have better governance for information architecture, and of course better interoperability with current international standards. We are using the CDA and so on, so for the primary use in the national level. Of course there are different standards that are being used between the organizations and so on. But the framework looks like this. So we need to model common logical data model, and there was this, who was it? Sule might have said that to go to invent something yourself or to go something that is existing on the market. I think we have the hybrid approach there. We have lots of modeling done nationally, and it's quite interoperable with OpenAir as well as FHIR. We have looked into those, and the context details, for instance, we have quite good set of context parameters for the data, so I don't think we are that bad off. Okay, common logical data model, information, contents and value sets. Value sets, of course, very important factor in order to make sense of the data. Then linkage to international terminologies, namely SNOMED, that hasn't been done earlier in Finland. And of course, I included the DICOM information object definitions here because it's anyway a huge part of the setup. But then where do we start? From the needs assessment, the day-to-day needs of healthcare, that is the primary focus and primary purposes of use and value assessment based on that. But of course, we have the secondary purposes of use as well. We need to make some kind of compromise with those. We have lots of existing specifications, of course, the stuff coming from the EHDS, the logical models, and the EEHRXF. Current information contents from Finnish Termeta system, as well as the current information contents from the national code server. Then the international references. The base model, we are using FHIR resource types, but of course it would be stupid not to use the clinical modeling from OpenAir as well as NEMSIS and for the emergency medicine and so on. So hopefully we get a funnel where we get wisdom from multiple directions. Then for the data interchange, of course not actually part of the data modeling, but we are moving slowly, but moving towards the national FHIR profiles, and we of course will have the current CDR2 definitions for a long time. There will be the EHDS stuff and DICOM stuff as well. Oh yes. Some thoughts in the end. I have 4 minutes, maybe we can have one question or so. So top-down governance, something that we have had some experiences on that result in uneven modeling. We give some specialists a task to model something, and there might be very low-level stuff, and in the other parts it's very high-level stuff. So that kind of governance is needed. Data model, of course, is essential for the quality of data, and there is, of course, a trade-off between strictness and the burden on clinician. And it has been noticed, of course, that if the data has no relevance in clinical work and clinician must still produce the data, it will probably be crap. I have this one example where a nurse, when discharging the patient, needs to pick one value from the set of maybe a dozen. Also, where is the patient headed next? And they are quite close to each other, and usually it seems that the nurse picks the first one that is understandable or somehow fits the bill. So even with all the talk about the patient-centeredness, we need multipolarity. Rich context allows for different viewpoints. That is, of course, especially true in open air. Standards will always be lagging behind when it comes to development of healthcare, but it's still, of course, important. This is, for instance, the DICOM, even if it's an excellent example, but still some of the studies benefit from those ICT vendors' specific tags or more accurate definitions or so on. And the DICOM is somehow anyway standardized in a good and bad way. And data model is, or information model, whichever, is a complex issue. Few people really understand what data model is and does or does not. There has been lots of kind of discussion in Finland that if we have this data model, then everything will be fine and data will be moving across. And yeah, we still need data models. There are links if you receive these slides. These are for the references I had in this presentation. Thank you.
Thank you very much. Still have time for one short question and a short answer. No? Here.
Maybe I just add something. When you said that we don't have any published archetypes, I would like to emphasize that we use the international ones. So when you talk about published, it was like translated to Finnish. And there are a couple in the CKM, but we made the decision that we translate to Finnish only if needed.
Yeah, but aren't they localized? There are lots of...
No.
Okay, that's different.
That's the 90% rule, remember?
Yeah,
straight from the international.
Okay. Yeah, of course the basis is from the international, but what I discussed with the vendor, they said that they have their own archetypes.
No, the vendors also use the international.
Yeah, as a basis, but yes, okay.
Thank you very much.
Thank you.